So like we learned on Tuesday, most patients with spinal cord injury end up dying of respiratory complications, despite the fact that probably their respiratory system was not affected at the beginning. So we teach patients some techniques to help to keep the mobility of those joints so that the work of breathing is not increased. So the first one I'll show you is the therapist's auto-assisted mobilization techniques that the patient can do on their own if we started seeing this patient before they develop stiffness. And I'm going to show you some techniques the therapist can do for the patient, especially for those who are spastic, who, if just because of spasticity, it's difficult to move the chest wall, or who have developed stiffness already. So the first one I'm going to show you is what we call the S-shift technique. And we talked about this in class on Tuesday. So in the S-shift technique, the patient usually have intact diaphragm. Let me assume the patient has spinal cord injury. The diaphragm is intact, but the intercostal muscles are not working. So the chest wall is not going to be moving during respiration. And like we discussed in the class on Tuesday, because of impaired respiratory system mechanics, even though the diaphragm is intact, it is not the same thing in the normal individual. So their ability to breathe in is lesser, even though the diaphragm is contracting. Why? When the diaphragm goes down, the chest wall is going to suck in. All right. So we teach these patients to use the S-shift technique just to move their chest wall. I'll come to some other things about the breathing pattern as we proceed. And what we do is we place one hand, just like we do diaphragmatic breathing, one hand on the chest. So I'm going to ask my patient to take a deep breath. And when they breathe in, if the patient is C6, C5, C4, only the diaphragm is going to contract. So only the abdomen is going to move. So the abdomen moves and the diaphragm goes down, the abdomen moves up. And then I'm going to have air entry only to the basal lobes, right? Because it is only the diaphragm that is contracted. Then I'll have the patient close their windpipe. Tell them like you're going to the washroom, and then suck in your tummy. So that abdomen goes down, the diaphragm goes in. Because the windpipe is closed, that air that was sucked to the lower costal cartilage goes up to the chest wall, and the chest wall moves up. And that is like a passive mobilization for the chest wall to maintain the joints, the intercostal and costovertebral joints. So I want you to take a deep breath. In, close your windpipe and suck in your tummy. Then bring it down, again, and relax. Did you see what happened to her chest wall? As the tummy moves in, my hand here moved up. And she was not breathing. As she brought back her tummy, so I'm moving the air up, down, up. 2 to 3 times. I don't want to keep the patient's breath for a long time. Patient relax. I do that till the patient do that like around 10 times a day, just to maintain the joint integrity. All right. So those are the S-shift techniques.
This is for chest extension.
Apart from the S-shift technique, I have some stretching techniques that I show the patients for the patient to use. And some of them are positional. I'll just get something here. I think I am going to get something like a roller. Usually, I'm not in office, so I may not see this in a Euro clinic. I commonly use a towel, but if you can get a roller, that is fine. But I commonly use a towel to teach the patient this. I just put the towel and roll it up like a roller. The same thing, right? So I roll my patient sideways, right? And I place this on the vertebral column. And then have them go back and lie down. See what happened to her chest wall? It opened up. So I'm putting a stretch on the anterior chest wall. I can enhance that stretch by having the patient take off the arms. And I have the patient stay up in this position. Because remember, in inspiration, the chest wall opens up. In expiration, it goes in. There are no muscles to open up your upper chest wall. So positionally, I put them on stretch so that that rate of motion is maintained. So the patient just stays there. The stretch can be 5, 10, 15 minutes. Once a day, that's fine. For the anterior chest wall stretch. Then for the lateral chest wall stretch, I use pillows. So for this, I'm going to get either 2 pillows, depending on how big my patient is, or I can use 1 pillow folded. And then, so I'm going to place this and get my patient into side lying on this pillow. Okay. This is a good patient. I wish those patients can talk by themselves. But usually I'm going to put this, and let me take you in a little bit so that you're safer. Okay, good. So I position the patient like this. So the goal here, or the one thing you want to look out for here, you can increase the height of a pillow depending on how thick your pillow is, how tall your patient is, in relation to their thorax. But the goal here is that when I position this pillow, the patient's hips and the patient's shoulder must be touching the bed. All right? For her, I will put 1 more pillow, or folded 1 more pillow, maybe 1 more layer to put more stretch. So this puts a stretch. So if I put 1 more pillow here, I create a curve. All right? Putting stretch on her lateral chest wall. And it's just a position to provide stretch on these muscles that are not activated because they can get tightened. Remember, when patients have like partial injury, they can have neuronal recovery. But the problem is that times how long it takes, what's the rate of regeneration of nerves?
Very well.
The rate of nerve growth or regeneration.
Like Wallerian?
Sorry?
Like Wallerian degeneration and stuff like that?
Yeah.
1 year.
Millimeter per, I don't know.
So it goes at the rate of about 1 millimeter per, I can't even remember per what it is, but it takes a very long time. I can't remember, I think it's 1 millimeter per day. I can't remember, but it takes a long time for a nerve to regenerate. The problem with many patients with nerve injury is that even if their nerves has the intact ability to regenerate, usually after a traumatic injury on a nerve, by the time the nerve gets back, the muscle is no more there. The muscle has lost its contractile ability, capacity, it has lost its flexibility, it has lost a lot of stuff. So here on the lateral chest wall, I'm just putting a stretch to avoid stiffness on this. I can increase this stretch laterally by having the patient put the hand in abduction. All right? And I increase the lateral stretch. I can put the stretch a little bit on the anterior chest wall by having the patient put the hand, the shoulder in some flexion. All right? So, but for her, like I said, I will have doubled this pillow just to increase that stretch. So, those are to the therapist assisted, the auto-assisted and gravity-assisted positioning techniques that we are going to learn. I don't know if I'm going to post this slide for you, but I think you have all the information on your power pack, on your course pack. Now, I have the therapist way of trying to enhance mobilization, all right? And one of them is manual stretch. So these ones I teach them to the patient and their relatives. I can also do it for the patient, but it's something they can do without the therapist. But the manual stretch, I'm putting a stretch on the chest wall, anteriorly and posteriorly. So I'm going to first of all show it in, you can face up. I'm going to first of all show it in supine lying. Because of the ladies, usually, many ladies, especially if they have a big breast tissue, do it in side lying. But I'll show it in a traditional format first, then I can show it in side lying. So what we'll do is we'll place the heel of one hand lateral to the sternum. The fingers of the other hand goes posteriorly to the transverse process. All right? And so remember, this patient. Sorry? The finger goes to the around the transverse process posteriorly, and the heel of the hands goes lateral to the sternum. All right? Now, so this is my position. This manual stretch technique is common in patients with spasticity or patients who have developed stiffness. If you're seeing the patient once, depending on where the patient is an outpatient or still an inpatient rehab, at what stage. In the chronic phase 2, it might be good if the patient is coming as an outpatient. Your therapist will make sure those joints are flexible. But these patients, the intercostal muscles are either spastic or paralyzed. All right? If they're paralyzed, they don't have activity, so the costal cartilage is easier to mobilize. For her muscles are active, so it's not at times very comfortable as you try it on each shoulder in people who have each practice. So I won't push her so much. But what we do is that I bring this finger up and this hand down in a ringing motion, and I go up this way from the lower costal cage up to below her clavicle. All right. I'm going to show it in her probably in sideline, or I have a guy and I go up this way, and I go up this way, and I move and mobilize all those joints in a ringing motion with my hands moving up and down. All right. So that will move the costovertebral joints at the back and sternal-vertebral joints. All right. The joints anteriorly and posteriorly. Does that make sense? I'm going to show this again in sideline, or maybe I'm going to have a guy. So I can do this. So for ladies, when we put them in sideline, it gives us room to allow the breast tissue to fall by the side. And then I go this way. Not so comfortable, and I go up and up and up. I can have a guy. Let me show this.
This is where I come in.
Oh, okay. I'm going to show it on him again. So I'm going to go something like this.
Okay.
All right, so below the clavicle, and then I come back. And I do it on both sides. In sideline, I can do it this way, so I allow the lady's breast tissue to fall forward, and I mobilize this way. This move immediately. So it is just the therapist trying to put mobilization on that chest wall. So I am going to allow us to practice this, and then we will move over to facilitating breathing in patients. Any question?
The roar.
Okay. Sorry?
Second definition, the roar.
Yeah.